Great. Okay. Now we're live, my friend. All right, I'm going to introduce you in a few minutes, okay? But while people are start coming in,
Okay.
first I'd like to thank you so much, Dr. Teoman. We know you are very busy, and also you've been very busy these days writing your book, and you still separated some time to talk to us. So I'm very grateful to have you here today. You are one of the top surgeons in the world in rhinoplasty, and also kind of I say that you're kind of a mysterious surgeon because you have some wonderful techniques, and people always ask, "Oh, how Telman do this thing? How Telman do this? Tell strut, tell door suture," and nobody knows how to explain it exactly. But now you wrote your book, and now we have this webinar with you, and I think everybody here today can learn a lot from you. So
Yeah.
thank you so much for being here.
Yeah, I thank you, Fernando. It's a great pleasure and honor to be broadcasted here. And let's talk about the rhinoplasty.
Yeah, yeah, yeah. And tell me a little bit about um, your book, right? You spent some. I know there is a lot of work to write a book. Tell me, how was it? When did you start? And how was your feelings when you were writing your book?
Yeah, I started last year actually, and slowly it's building up. You write some pages on Word, you don't like it, I write again and again, and then at a point I said, now it's time. Now I'm ready to write this book. And then this outbreak started, and it was quite a chance for me because I couldn't work. I was at home in my home in Alaçatı, which where I windsurf normally, and I had the chance to work for, I don't know, maybe 4 months, like 10 hours a day if I want to. I was windsurfing if there is wind, and then I was working on my book. It was, it was a big chance for me to be able to, because otherwise it's probably impossible to concentrate so much on something.
Yeah, yeah.
And my feelings for the book, I'm in the OR for more than 30 years. When I was in high school, I was watching rhinoplasties. I was a high school student. And, with time, you feel like, you build up something. It's something coming out of you. And you want to put all these things together. And it's very difficult to make it a small, very small, a book that everybody can read and understand. This is really, really a challenge.
Yeah.
When I started, it was a book like this, and with time, I made it like this.
Okay.
And this is the most difficult part. You can write. I can talk on rhinoplasty for hours, and
Yeah.
But you are going to be confused. I have to tell you the real thing, the dish of it. You understand? This is very difficult. And I feel very satisfied. I feel like I'm done now.
Okay.
This book is my.
You wrote something that you did some kind of before writing your book. You were talking to some residents or some younger surgeons to know exactly what they would like to read on your book, or what was interesting for them. So that was important for you.
Yeah, that was very important for me. When I started writing the book, I didn't know this is the first book I was writing. I wrote lots of articles, but article is a format. You can't change it. All articles are pretty much the same, but books are totally different. And there are some books, some medical books that I loved a lot, and some that I didn't like it very much. And I asked to the young guys, young fellows, I said, what do you want? What kind of book you will prefer? And all of them told me they want something very short, to the point. Not, words like blah, 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 blah. They don't want to hear about unnecessary details. They just want to hear about the real thing. What do you do? Why do you do? How do you do? And they don't want any repetition in the book. I can write a chapter like how to shape the tip with my technique, and the second chapter is going to be how to rotate the tip with my technique, and third chapter is going to be how to make a projection with my technique, and all are the same. You do something, and you're going to have the shape, definition, rotation, and projection at the same time with the same thing. It's not different. So, I try to not to repeat anything in my book. So it's very compact. So you can read it in like 3 to 4 hours. You can read my book from the beginning to the end. And probably if you are a surgeon with some experience, the next day you can do the same thing. Because the rhinoplasty is all about the technique.
Yeah.
The sutures, we know how to suture, we know how to put the grafts, we know everything, we can do everything, but the real thing is how we do it.
Yeah. And how long have you been in practice with rhinoplasty?
Even in high school, I was looking at rhinoplasty surgeries. But I started my residency in '94, and my professor was Ayhan Numanoglu. He was a very good rhinoplasty surgeon. He was very famous. He was maybe the best in Turkey. I had really a chance to see him he was very fast, and he was a very good surgeon. I saw thousands of rhinoplasty from him, and it was a big chance for me. And talking to former rhinoplasty, blah blah, and then I started in 2000 doing it myself.
Okay.
Yeah.
And how do you see this learning curve in rhinoplasty? Are you still a learner in rhinoplasty? How is that?
Yeah, of course, I'm still a learner. I also wrote a sentence about this in my book. This book in your hand is already outdated. Because I'm still learning. I'm still changing everything once more, and I can't quit easily something that I was doing for 10 years. I can say, doesn't work, this is better, and I will shift. If I do this, please don't, in the future, don't think that, I was lying. This is me. I can change in an instant. If I see one thing is better, I will shift. And I think this is a very good quality for a surgeon. We should not be, stuck on something. I'm looking for the best. And if I find the best, better than I do, then I will accept it and I will change my direction to this.
Great.
Yep.
And do you have you like windsurf, right? You're in New Zealand.
Yeah, I go to Brazil every year. I go to Jericoacoara. It's my favorite spot, really. It's a paradise. It's a windsurfer paradise, especially when you go in the winter time. I can spend all my winter in Jericoacoara. Good waves, easy spot, perfect conditions.
Is there where you recharge your energies for your rhinoplasties?
Well, maybe it's the opposite sometimes. I charge my energy for windsurfing and rhinoplasty. I operate, I feel better, I go windsurfing. I'm both of them.
Great. When we love what we do, it's not a work, correct?
Yeah, it's not at all. I never felt like I'm working on plastic surgery, anything on plastic surgery, not only rhinoplasty. But I decided to become a plastic surgeon when I was in primary school. I said, I'm going to be a plastic surgeon. People, they were laughing. He's crazy. I was like, I'm going to be a plastic surgeon. I was fascinated with old cadavers, blood, sutures, and things, everything. Yeah.
Great. That's amazing. And that's amazing how you took your time during this pandemic to write your book. It's very nice because some people find problems with the pandemic and some other people find opportunities, and you found a very good opportunity to write your book. Yeah. And I also did the same thing with my mentoring program. And I remember one time, just a brief story here. Last year, I've been to Turkey like 6 times. I love your country. I love the food. I love people. And I love rhinoplasty surgeons in Turkey are the best. And one time I wrote and you were writing your book. And on that time you said...
I remember, yeah.
Yeah, and you said very you were very nice with me, and you just wrote, "I'm sorry, I cannot I cannot accept any visitors for now because I'm writing my book," and that created on me a very big expectation, and I'm very excited to watch your lecture today. And I know that many people around the world are here today. We have so far more than 300 people watching us, and everybody are curious about your techniques because you post on Instagram some very nice results, very nice and fast recoveries, and with no casts. Tell strut, tell their sutures. So a lot of things
Yeah,
that maybe you're gonna go over all these today,
yeah.
right?
Thank you very much. I'm going to try to a little bit expand the interesting parts. Everybody wants to know how this thermostat works. What is thermostat? What is the secret of it? So I'm going to tell you now. And but but I'm going to try to explain also the idea behind it. If you look something only technically, everything is at the end it's just a graph and 3 4 sutures and it's going to work.
Yeah,
But there's always like something else behind it that makes everything works.
yeah,
So I'm going to try to explain why I do it and how it works. What is the
perfect.
difference? Okay.
Perfect. Thank you so much. So, before we start, now we have a lot of people here, almost 350 people, and I know that more people are coming in. And before we start, I just like to invite you all. Okay, this next week we're starting a free um, rhinoplasty mentoring week. Okay, in our academy, we're starting 1 week with some basic stuff and also some advanced stuff about rhinoplasty. It's gonna be a pleasure to have you all here. We're gonna send on our chat. I can send the link so you can subscribe, and it's gonna be some sequence of videos in which you can know a little bit more about rhinoplasty and also about our mentoring program. So it's going to be a pleasure to have you all there. And um, I'm going to share the link in the chat. Okay. All right. So now let's start. Um, Telman, Dr. Telman, he doesn't need any kind of introduction. You all know him. He's a plastic surgeon. Everybody in the world knows him about his beautiful results in rhinoplasty, but also because of his very fast recovery post-operation with no casts, and how he does these struts in the nose in the concepts of preservation rhinoplasty. So it's amazing to have you here today, Dr. Telman, and I know it's going to be great to listen everything that you separated for us today. Thank you so much again.
Thank you very much.
Okay, I'm
So,
gonna put your screen here, and whenever you're ready, you can start.
all right. Yes. So, do you see my full screen, right?
Yes.
Yeah. And can you see me as well? I'm not very
Yes.
familiar with
Yes.
it.
You can see
Yeah.
you. Yeah.
So let's go. So let me talk about the idea behind the whole story, actually, the rhinoplasty. So I'm going to repeat it in all my talks. I think this is crucial, this is very important. Aesthetics is directly related to function. As rhinoplasty surgeon, we have to really understand this deeply. And that comes from the evolution. By our instincts, we find noises that breath and smell well as beautiful. But this is not only for noises. For all mammals, they're gonna lack from the other sex some specialties. Some, like lady is gonna lack the man with muscle because man with muscle gonna protect her and the kids. And the same for the man. He's gonna look for a young and healthy and beautiful shaped lady because she's gonna give her a good offspring, children's. You understand? So this is exactly the same thing for our job. So if you find a noise is beautiful, I'm 100% sure this noise is going to be breathing very well. So we also have to know that instincts cannot be learned. We all have it by nature. When we are born, we know how a good noise, a beautiful noise looks like. So all my story, all my technique is based on the first moment of the surgery. This is the first step in my technique. Are we connected? Can you hear me?
Yes, yeah. Yes, I can hear you.
Yeah. Because you also.
Okay.
So when I start the surgery, I shape with my hands the tip, and I try to find the most beautiful shape of the tip. And then I'm going to make all my surgery according to this tip shape. This is the most important idea behind my rhinoplasty operation. So this is really 90% of my technique. Let me show you how it works. So this is the beginning of the operation. No injection, just anesthesia. I sit just behind on the right side of the patient, and I try to find the most beautiful shape on the tip, and then I mark it with the pen. This is another patient. I shape the tip, and I'm going to mark the point. This is the peak point, my new tip point. Let me show you one more, another patient. So you can do it by yourself, with your wife, kids, and loved ones. Just try to find this tip point. This is a very good exercise. But it looks very simple, but there are lots of things going on there. So what I do is I shape with my fingers and find a new dome. But at the same time, I also correct the resting angle. And the resting angle is the single most important variable in all rhinoplasties. My technique, rhinoplasty, is all about the resting angle. And at the beginning of the operation, I find the new point, tip point. I try to, shape the tip with the resting angle, and then I'm going to mark it, and this is going to be my surgery. So let's have a look. So this is the anatomy, and this is the skull ligament here between lateral crus and upper lateral cartilage. And resting angle is the angle that lateral crus and the upper lateral cartilage, they have in between them. So if you look at noise from the downside, so what you see black here are the lateral crus. They can stay like this, or they can stay like this. But there's a huge difference in between them. This one is the bad resting angle. And this one is the good resting angle. And the bad resting angle is going to look ugly. And the good resting angle is going to look beautiful. This is crucial to understand what's going on there. So this is the resting angle. And also for the function, resting angle functions like a venturi tube. So let's talk about this venturi a little bit, and then I'm going to go to the surgery. It's too much theoretical, but this is very interesting, I think. So this is the venturi effect. When you have two long buildings and you have the wind is going to go much faster in these buildings, because when the airflow or a liquid flow is squeezed, it's going to go much faster. This effect, we call it venturi effect. And same thing happens in our noise exactly at the resting angle, at the scroll ligament. At the resting angle, a healthy, nice resting angle is going to squeeze the air to some point, to the right exact point, that a slow airflow is going to become very fast into the airways. We need this because with speed of air, the air is going to reach the alveolus. We have to understand that respiration is not the amount of air we take in our respiratory system, but respiration is the amount of air that reaches the alveolus. So to reach the alveolus, here, the air needs to gain some speed and then go to the alveolus. Otherwise, it's like breathing with your mouth. Think about yourself. You have flu, you can't breathe from your nose, and you sleep with your mouth open. And then in the middle of the night, you're going to wake up breathless. Why? If you think about why, because your mouth is huge. Actually, you can take lots of air, but still you feel that you can't respirate. Because, the air cannot gain any energy, kinetic speed energy, and cannot go into the alveolus. And if you can breathe from your nose, and then it's going to get some speed, and with a little bit muscle effort, it's going to go directly to the alveolus, and we're going to call it a good respiration. This is very important to understand this. So a resting angle, which is bad, not only looks ugly, but also breathes very bad. And a good resting angle, which looks actually beautiful, also breathes very, very good. So this is what I told you at the first sentence. The function is directly related to the aesthetics. Good function looks good. Bad function looks bad. How to practice? Just practice at home with your husband, wife, and children, and try to find this. This is exactly done like this. You see my nose. I have a not the best nose. Okay. But when I respirate, I feel like this. But when I give this shape, then I will respirate much better. Because I shape my resting angle. I find a new tip point, and I respirate better. And I look actually better like this. So my technique has 20 steps. And this part was the first step, to find the correct resting angle and the new tip point. But I know you guys, you don't want to hear about these theoretical things, and you want to hear about this theostrat and what I do for the tip. So let's go fast and let's jump to the 15th, 16th, and 17th steps, right? So what I do for the tip. So this is the 15th step, hemitransdermal sutures. Hemitransdermal sutures belongs to Dr. Grubers. He published it in 10 years ago, in 2010. And it's a very good idea. And the trick with Gruber sutures, the Gruber suture is gonna make the resting angle position on the correct way on the dorsum. But to be able to put these sutures, first of all, we have to have a new tip point. So how to find the new tip point? So this is the step 2 on the operation. When we put the markings, and then we're gonna pass some needles. Another needle. These are very tiny. We call it dental needles in Turkey. I forgot how the gauge is written in my book. It's 27 gauge, I think, something like that. They are very tiny. You should not use a big one. So you're gonna pass methylene blue, diluted 1:1. If you do it this way, you are not going to make a big mess. So this way, you're gonna have your tip point on the cartilage, which is marked. Now we can work on the cartilage. So on the drawing, this is the same. You put the point with your pen. Check it again. You put the point to the symmetrical sides. If you watch to the cartilage, you're going to shape the cartilage, and you're going to put the mark on the skin, and then you're going to pass the needles. And then you're going to pass the methylene blue, and then you are done. So now we know where our points are. They are there. Then I put some more marks on with my pen. So this is a typical Gruber suture. When you put the Gruber sutures, you should not make them too tight. This is very important. You know, this one is going to be tighter, but this one is going to be less tight. I usually put like 3 of them on both sides. You know, mostly one single suture is okay, but you know, more sutures are for security. Also sometimes for shaping as well. So it's going to be on the capital A letter, the same shape. So the Gruber suture is going to shape your resting angles. This is very important. So look at this. In this picture, you see the preoperative shape of the patient, and the lateral curves are on the wrong shape, on the wrong position. They are like this, okay? And at the end of the surgery, now the lateral curves are on the good shape, and the nose now looks very nice. So you can see this difference just by looking at these pictures. So let's have a closer look for the shape of the lateral curves. Here, the lateral curves is almost vertical, standing vertical like this. And at the end of the operation, it's almost horizontal, looking to the sky. Let me show you again. Pre-op and post-op. This is very important. And if you look from the top, from some other angles, you're going to see more clearly the difference, the effect of the shape of the lateral curves to the tip. So this is another patient. Watch carefully. Preoperative, the lateral curves are like this. And here, postoperative shape, and the lateral curves now are like this. And you can only do it with Gruber sutures. You know, I know you like very much these animations. You know, they are fun, they look nice. You know, our patients like it very much, blah, blah. But, you know, if you look carefully, you're going to see also some details that are very useful for our job. Now the shape is wrong, and now the lateral curve shape is right. The resting angle is wrong now, is vertical, and now it's horizontal. You can see the difference clearly on these animations. Same here. Look carefully. Good one and a bad one. It's very clear. Okay, let's talk about Teostat. So this is Teostat. This is simply a piece of cartilage sutured at the end of our septum. And it measures something like 25 millimeters, which is 2.5 centimeters, and you know, almost a centimeter here. And this part is usually a little bit pointed, or it can be 2 millimeters, 1 millimeter. It's not very important. And I usually harvest this graft from the top of the dorsum when I do the push down. So let me show you how I fix Teostat to the septum. This is the easy part, and the part which is not very important. So this is the Teostat. Before I suture it, I try to find the angle of it. You know, I put it so I can see which angle I want it, because it's going to affect the shape of the tip, the rotation of the tip. So I'm gonna fix it usually with some needles, and I'm gonna use Proline sutures. So it's going to be very well fixed. More sutures to both corners, and some more sutures here you can see. And you have to fix it well. I mean, this is the trick. It should not be moving back and forth. But the graft itself, a good graft, is going to be flexible. I think this is the crucial part. This is the most important part and difference from all other grafts. It's a graft that you can move when you suture it, when you fix it. So let me show you the video. So I'm done with the dorsum. And I shape my theostat, and I try to find its angle. I usually put it like 80 degrees if you calculate from the top. 80 to 90 is okay. It should not be over-rotated. Because what you see in the operating table is going to be what you get in the coming years. So you should not do any overcorrection. So I put more sutures. I use Proline because I stop using PDS like sutures, absorbables. I can't trust them. Some more sutures. Well, this part is the easy part of the theostat. So you're going to fix it. You have to harvest a nice graft, and your graft should be from the top of the septum, not on the bottom of the septum, because the bottom part of the septum has the quality of the cartilage is much less, and you can, the cartilage is very thick on the bottom of the septum, and the best cartilage always comes from the top. You have to be patient at this step. You have to suture it very well. So this is the most important part. You see how flexible is the theostat? This is probably one of the biggest difference with any other grafts. All other grafts are, you can call them extension grafts or other names, but they are going to be solid. They're going to stay there. They're not going to move. So that was the easy part. And now let's talk about how to fix the tip to the theostat, which is a little bit more complicated. And actually, this is where the devil is in the details. So this is where theostat is probably differs from all other grafts that we use on the tip. The trick here is theostat is fixed to the dome, but only to the dome. you should never ever use any sutures between the medial crus to the theostrat, and also from the lateral crus to the theostrat. The only fixation should be here. This suture is a single point fixation of the whole tip to the theostrat. So at this stage of surgery, you're going to see something like this. And then when you are done, your tip is going to move. Your alar cartilages are going to move with the theostrat to the back, middle, and to the front. And that's why at the end of your surgery, your tip is going to be mobile and elastic, which is crucial. I think this is the biggest difference with many other grafts. So let me show you one more video. And this is from an open surgery. That was quite a bloody patient operation. But you know, here you can see very clearly how I do the surgery. It's not the best theostat I ever done, but still you can see a lot here. You know, I strongly recommend that you guys start open. You know, in open surgery, it's very easy to do to apply the theostrat, to do tip sutures, and you know, to see everything at once, and you are not going to have any complication and difficulties in open surgery. And when you feel comfortable with open, after maybe 20 to 50 patients, and then you can go for the closed. So this is the same story. So now, sorry. Now, what I do is the figure of 8 suture. So here you have to fix both domes to each other. And you're gonna do it on the back of the theostat, okay? Sorry again. Okay, this is the figure of 8 suture on the back of the theostat. And this day I did another suture. No, but I don't do this. But you can do it. It's a little bit new in my technique, in my practice. So I fixed it with one suture. And I'm going to put another suture just for security, but a suture that is not going to change the shape of the tip. So it's done. So this is the figure of 8 suture. I pass from one side, from the other side on the reverse side, tied it on the back of the theostrat, and then I pass another suture to fix this new shaped tip to my theostrat. I'm going to pass from there and grab it and tie it. Now you are done. This is the only fixation you have to do. If you try to fix here, or especially on the lateral crus, if you try to fix the lateral crus to the theostrat, and then you're gonna have problems. That it's not going to be a theostrat. It's going to be a, I don't know, a extension graft, or you can name it. And it's going to be looking something like this at the end. This is the figure of 8 suture. And when you are done, and then you're gonna cut the excess of the thermostat. There are, of course, there are many tricks. I have to show you the full story, but this is really the how I do, in fact, the idea behind it. So let's talk about the L profile also. I know you never heard about it. L profile. The idea behind the L profile is like, in engineering, we use a lot this shape of steel. When you have a plate like this, one single plate, if you apply pressure on it, it's going to bend easily. But if you have two plates, and if you put them on a 90 degrees angle, they're gonna hold each other on a stable position, and they're gonna carry much more weight that they are facing from the up, and they're gonna carry more weight. And believe me, this is exactly the same thing for anatomy on a natural noise. You have the medial crus here, and you have the other medial crus here. In a natural noise, the angle between them is 90 degrees. And in a natural noise, in a normal anatomy, there is no connection between the two medial crura. They are totally separated. There are soft tissue between them. So normally in surgeries, we usually suture one medial crus to the other, which is quite wrong if you look from the anatomical side. So I changed this. And now what I do, I suture the soft tissues on both sides together, and I try to reconstruct the normal anatomy. And at the end, I have both medial crura. They are facing each other on 90 degrees, like an L-shaped strut. So in this way, you don't need to use a columellar strut or anything else, and your columella shape is going to be very stable, even if you press on this direction. So this is a nice drawing of it. So you try to hold the mucosa on both sides. Actually, this is the mucosa that we cut during our dissection. This is the pitangel ligament, the deep part that we cut when you dissect it. It's there. If you suture them together, you're gonna reconstruct again. It's going to be a natural noise. That's why I never use any columellar struts or other grafts in my surgery. So let's talk about why I do the theostrut. Where the idea comes from. Well, the thing is that we have to talk about is, in rhinoplasty, the basic problem is all tips, somehow they do drop. And to understand how a tip drop and why a tip drop, you have to check the step 19 in my technique. This is the Özkan test. This is the page 107 in my book. And Özkan test is going to show how the tip will look like in the postoperative period. And if you look carefully, a negative Özkan test is a perfect simulation of a tip drop. Let me show you how it works. So there's a theostrut here, and this is a positive test. So I press on the tip, I wait, I press again, and I press again. And the end result is what I'm going to see in my office after a month, after a year, even after 10 years, maybe. My tip is going to stand like this. So this is good. My tip didn't fell to the ground, and this is a positive test. And this is a negative test. Now you're going to see a very nice presentation of a tip drop. This is during surgery, and this is before I inserted my theostrut. So I have here my epitangle ligament that normally should carry my tip. So I started like this, and I end up like this. And believe me, this is a good scenario. And this patient should be quite happy, but not this patient. Look at this. No theostrat and theostrat. You know, this patient, at the end of the surgery, she's going to see this result, and she's going to be very happy. After a week, when you remove her cast, she's going to see this result, and she's going to tell, at the end of surgery, my tip was, you know, standing very nicely, very well projected, and now it dropped. Even after 10 days, she's going to tell you this basic sentence. So we also have to answer the question, why tips look good just after surgery? I mean, why when we finish the surgery, our tips look so nice, and after a week, after a month, they go to draw. What makes them look so good on the table? Well, the answer is very simple. This is suture tension. Tension, because, you know, during surgery we use lots of sutures, and all we shape all the cartilage and everything with our sutures. And there are some tensions on all our sutures. And in normal healing period, in normal human anatomy, no sutures will hold their tensions for more than a week. You know, all tissues are going to change some shapes, and, you know, some edema, and many other things are going to happen. And, you know, tissue, they hate this tension on them, and they're going to get rid of this tension somehow. And after 10 days, your sutures are going to have much, much less tension compared to the end of your surgery. And then your tips are going to get, you know, like collapsed, like dropped. So if you want to improve, I strongly recommend always do an Özkan test at the end of your surgeries. And it's going to show you exactly what you are going to see in a month. Just do it. It's going to take your 10 seconds. And then you're going to see what's going on after a while. Yep. So my surgery has 20 steps, as I told you. You know, we were talking about the tip mostly. And you can do my surgery, my technique, like open or closed. And you don't have to use any cast for the dorsum, because, you know, it's going to be fixed by Theodor suture or Theo suture, how we call it. And I almost never use a splint unless it's a secondary surgery with lots of work on the septum. Then I'm going to use maybe some silicone splints inside. But, you know, drains or things like that, I never used. Well, my last word is like, rhinoplasty actually is an easy operation. And I strongly believe that we make it a little bit complicated ourselves. Okay, thank you very much, Fernando.
All right, Theo. Thank you so much. Was amazing presentation, very clear. I was, like I said in the beginning, I was very curious about Telstrut, and once you released your book, I could understand exactly why your tips are very stable, and it's very interesting. So I have some doubts. I don't know if you were planning to show a little bit of your dorsal preservation, because you use a lot of high strip, correct? And
Yeah.
how do you design your high strip, and from which part you remove your strip? Because I have difficulties in cases of septum deviation. I have difficulties to do high strip in all these cases. How do you manage that?
Let me find you. Let me find you this step. Yeah, actually remove from the top of the septum, and if there is a deviation, and then I'm gonna remove usually a new strip on the bottom of the septum. But you know, it's quite an advanced case. Usually, what makes the septum deviated is mostly the septum is too big to stand in the noise.
Yeah.
It's like a man who cannot stand on a small ceiling, on a low ceiling, and the man is going to stand like this. And when you remove the high strip from the septum, in most of the time, the septum is going to be able to stand like this. And your deviation is mostly cured at this stage of the surgery. But if there is a huge deviation and you cannot correct it easily by just removing the high strip, and then in this case, I also remove a low strip. But you know, this is a difficult situation because then your septum is going to be fixed on the back. So you should not do any dissection on this part. Your mucosa should be intact on the back of your septum, and you should not remove a lot from the bottom. And in some cases, I just cut the septum. It's going to, step on one side, and I'm going to suture it there. It's going to stay there. But I'm going to relax the septum, the tension on the septum. The tension comes from the height of the septum. The septum is too high, so it's going to be banded in the noise. So you have to release it. If you don't release it, whatever you do, scoring and adding some grafts and using some force on it, it's not going to work on long term. It's going to leave it bent on some side or other side. During your surgery, it should be relaxed and free and standing on the midline as much as you can. And the good part on this technique, your septums must not stand really on the midline. If your septum is a little bit deviated at the end of the surgery, but you can't see it from on any other directions, which is the case usually in rhinoplasty, because septum is not very important. You're going to remove the high septum, and this part of the columella is going to be very stable. You just need the septum to push a little bit the columella from the backside.
Okay.
So everything is stable, and if everything is well and your septum is a little bit deviated inside, you can leave it like this. And believe me, little bit deviation is also part of the human physiology. We all have little bit deviations. I never saw in my life a patient with a perfectly straight septum. All septums are a little bit deviated. If something happens in all cases, that means this is the normal anatomy.
Okay.
So we must not, correct all deviations.
Correct. And in very, I know in Turkey you have some very big humps, and in those very S-shaped humps, do you can still apply all your techniques, or do you switch for another technique for dorsum treatment?
No, I never change my steps. I always do exactly the same for all my patients. What I change is like some steps are very dominant in some patients, and on some steps are maybe not very important. Even sometimes I'm not going to do this step. I said I'm done. But if there's a C-shaped dorsum, anyway, I'm gonna rasp it. I'm gonna make a tunnel, very tiny tunnel. I have a very tiny rasp, which I call Teorasp. I'm gonna go there. It's like 2 to 3 millimeters wide. I'm gonna just rasp the top of the C-shaped hump, and it's gonna relax it, and it's gonna you need this top of the key point should be a little bit open when you make the push down. But
Okay.
here also, the Theodore suture, my suture technique that I do with the needle, helps me a lot. This is also a very important part of my technique.
Okay. And so most of your cases you do without dorsal dissection. Is that correct?
Yeah, but I always do a little tunnel there.
Okay.
Yeah, I'm not always, but most of the time. Because, when you rasp it, and then you're going to have a better shape, and the operation goes much faster.
Okay. All right. Okay, great. We have, I'm sure I have many other questions for you, but I'm going to open here for some questions from the audience, okay?
Sure.
Okay, so let's start here with some questions. A lot of people from all over the world. We had here more than 450 people from Latin America, a lot of people in here. Let's start. Okay, how do you manage the edema and ecchymosis in your patients?
Well, I don't do anything special. I just try to do my best not to have the edema ecchymosis on my patients. And, every steps of surgery, everything you do is very important for the edema and ecchymosis. And believe me, most of the time, the edema and ecchymosis doesn't come from our surgery, but how we touch the noise during surgery. I see sometimes my friends or my colleagues, they're so harsh to the noise during surgery. They touch, with their finger, they push this K point many times, and then ecchymosis starts there. I don't have a simple answer for this question, but this is the way we do the operation. Makes lots of difference.
Okay.
At the end, we all do the same things. We're gonna do some lateral osteotomies, some rasping, and things like that. And they are, of course, all of them, they're gonna do some bruising somehow. But the way you inject, the injections, what you inject, how much you inject, all these, which needle you use during injection. If you use the wrong needle, at the end of your surgery, your patient is going to be, all black and swollen.
Great. So another question about your morphine effects. Do you do it by yourself, or you have any kind of special?
You mean this animation? No, this is Özkan who does it. Özkan, the guy who named the test, the Özkan test, comes from Özkan. Özkan is my, he's my right hand. And he takes all the videos, all the photos that you see in my presentation, in my book, and, and he's like my pupils. He's going to see everything, take pictures, videos, and he's there. And we're going to talk a lot about the techniques. He's going to, take all my videos, work on them. He knows everything. And he's the one who does these animations. But, he told me that it's a very difficult job. Each one takes him maybe 6 hours. It's a very professional job. I have no idea how he does it. But as far as I know, he doesn't use only one single technique, one single program. He uses Photoshop and other things, and they mix up and take pictures and put them together. And it's quite a job. Yeah. And in my course, he's going to make a little 15 minutes talk on how to make it. Okay. If you're a pro, if you're interested, he can teach you how to do it.
Great. And about these sutures, do you use only Prolene or PDS? You don't use in any place?
No, I use PDS on many points. But if on some points that if the suture is important for me, I'm going to use Prolene. I use 6-0, and for now I have no problem with 6-0 Prolene. If you use 5-0, I'm sure you're going to have problems in the long term. But 6-0, if you place the notes carefully, then it's okay. We can use it.
All right. Another question here. Maybe you already answered, but a doubt about how do you keep your tip on the center position if you have a deviated anterior septum?
I think it's a very good question. Yeah, the thing is, the Homo sapiens is asymmetrical. We are all asymmetrical. All our faces are very, very asymmetrical. So we don't have a midpoint. So in any surgery we do, at the end of the surgery, our tips are not going to be standing on the midline because there is no midline. So you try to put the septum on the midline, and you're gonna put the theostrat on the left side or right side on a way that is going to be put your tip just on the point that you wanna see your patient at the end of the surgery. I usually make a turn around the table many times during surgery. I try to see where I want to put my tip. This is my choice. You can put here, or you can put there, or you can put there with any patient.
Okay, great. And any problems when harvesting tail strut? Because wide triangular shape, and any collapse if you have to harvest a larger part of the septum?
I don't harvest a larger part. This is the graft that I was harvesting before I started Teostat. I was doing pushbacks, and that was the graft that I was harvesting. But the trick is you can harvest anything you want from the back of the septum. You don't need a septum on the pushback surgery.
Okay.
You just need the septum on the supratip area. You should be very careful on the supratip area, and that's why my grafts are triangular. Because on the supratip area, I have the septum, and then upper lateral cartilage starts, and then I can go deeper. I can go very deep if I want.
Okay.
Okay.
Great. About septal deviations, low septal deviations, do you always treat them close to the vomer, maybe?
No. I think we over-operate sometimes our deviations. Well, there are two reasons for us to operate on deviations, to do a radical surgery. First one is respiration. If there is a block on the respiration, if the airways is really blocked, then you can go for it. Okay. And the second one is aesthetics. If your deviation, like the question that our friend asked me, if the deviation is visible outside, if your tip cannot stand on the midline, if it's going to bend some sides, then you have to correct it. But otherwise, if the airway is open and aesthetically you don't see it, just leave it.
All right. Dr. Alessandro from Brazil. Two questions. First one, it works in thick skin or just thin or medium skin?
Well, I know you have lots of very thick skin patients. I think it works better on thick skins. In thick skins, it's very difficult to have a good projection because thick skin patients usually have a very weak cartilages and small cartilages. The skin is huge, very strong, but the cartilages are, amazingly small and weak, and, they cannot carry themselves. So when you put the theostrat gonna carry everything, your tip, and it's gonna elongate the skin, and the skin is going to look much thinner with theostrat. So I like, I feel very confident, and I want to choose the patients with thick skin. I like them.
All right. Okay. And he's asking another question here. When the patient smiles, the tip stays very stable, or it tends to fall, or something like that?
Well, the theostrat, the tip is not fixed. It's going to be mobile like this with all the studs, and also the septum is something flexible. Septum is going to bend on the sides, so the tip is going to look almost natural. And yeah, but if you smile, your tip is going to standing almost vertical. With smiling, it's not going to change a lot. And patients usually they don't like their tip moving too much with smiling. But when we smile, our tips gonna drop a little bit.
Okay.
I also believe that this, we are too much concerned about this smiling thing.
Yeah.
Patient, they wouldn't care so much. When we smile, all our face gonna change shape. All the muscles gonna retract some parts. The noise is going to be larger, blah blah blah. But it's not very important. I mean, we are smiling.
Yeah.
So I don't understand why do we I see so much photos of smiling patients from the sides. I mean, it doesn't tell me anything at all from if patients smiling. I want to see the natural shape of the noise. Smiling, okay, even I see sometimes the patient preoperatively smiled and the tip of the patient didn't change. So postoperatively, she smiles and the tip of the shape doesn't change. So what's the point?
Okay.
It's stable. It was stable and it's stable after surgery.
All right. Okay. Here another question. Okay, and yeah, if you take 8 millimeters from the top of the septum, his question is, if you take 8 millimeters, do you think it lowers too much the dorsum on preservation?
Good question, Dr. Omar. No, it will not, because the problem on the dorsum is always the reverse. The problem is going always the recurrence of the dorsum. Never ever you're going to have a problem on the dorsum that you made a too much reduction with preservation techniques. I don't know if you agree with Fernando. But the problem, the complication is 100% is always the recurrence of the dorsum. So the dorsum will never ever go down more than you planned. So you can take any septum you want from the down of the bone area for the pyramid.
Yeah, I agree with you. The problem is recurrence. But in some of my first cases, I had some supratip deformity, but probably because I removed too much cartilage here on the front part.
Yeah, Fernando, this is supratip area is different. In supratip area, I still have sometimes complications like this. And, even in my book, there's a chapter about this, what are you going to do if that happens? Because it still happens to me. Okay. Sometimes at the end of surgery, I took too much and I put a little bit of graft. It's very easy to correct. But, you have to be able to see it and don't panic. Just put a little bit on other cartilage graft in a tunnel and it's going to stay there. It's going to be perfect. But it's very, difficult amount of cartilage you decide to take there.
Okay. So when you notice inside the surgery that you removed too much, do you put a little graft on the top of the dorsum or on the dissected area?
Yeah, usually I have a tunnel here.
Okay. Yeah.
It's a very tiny tunnel, like 2 to 3 millimeters. It's just one instrument that you can pass like this. And then at the end of surgery, if I see that there's a problem there, then I'm going to take out the what I resected from the other cartilage, from the lateral crus. I'm going to cut it. I'm going to put it there. I can put it another one. Even after the surgery, so I finished the surgery, I said, too much. And then everything is sutured, is done. And now what I do, I'm going to take my tiny scissors. I'm going to make a hole, just a hole there. And I'm going to insert a little cartilage because the tunnel is there. I'm going to put a suture and it's done. It's going to take me maybe 3 minutes. But you have to see it before surgery. A supratip, reduction, too much reduction never looks well.
Okay. And just one, let's go here. One more questions. Can I ask you a little bit more questions from the audience?
Any questions? I'm very happy. Ask me all questions. Yeah.
Okay, thank you so much. All right, here. how do you treat the free space in the supratip and between the medial crura?
I don't get the question well. How do you treat the free space in supratip
Yeah,
and in the
maybe I understood the medial crura maybe because the tail strut is just on the dome
Yeah.
area, but in the lower part you don't have any grafts, right?
No, I don't have any grafts, but I have a very stable fixation there with this L-shaped
Okay.
fixation of both medial crura. And this is the natural anatomy. Normally, we don't have a columellar strut in our anatomy.
Okay.
And we don't need a columellar strut.
All right. And how do you manage bone structures with piezo or chisel or saws? How do you manage that?
I use, well, I don't do any dissection. That's why I cannot use piezo. And I never used piezo in my life. And well, piezo is probably a nice technology, but it's too much work. It's very slow, too much water everywhere. And usually my friends who use piezo, they have piezo, they have osteotome, they have other instruments, and at the end of surgery, you always see them tapping on the bone. So, I'm not very fan of piezo for the moment. But hopefully, with time, these guys, they're going to develop the technology, and we're going to be able to use the piezo or another technology from the skin. And then it's going to be excellent. So what I use usually, I use the magic saw of Surya, Dr. Schneider, my friend. He has a magic saw. It's a very hand saw. It's a very simple instrument. And I put it there. No dissection is necessary. You just cut it with your hand. And in 50% of my cases, I also tap a little bit with my lateral osteotome.
Okay.
And then for this area, I use my 1.2 millimeter osteotome. I make a little cut here on the radix, and I cut the radix. And I have also another magic saw that I designed myself from Surya's idea, and I cut the sides, and then I make the dorsal mobile. But the skin is intact, so everything is attached to the skin.
Okay. And if you perform all the fractures, lateral fractures, and transverse fractures, what do you think is the little secret for you not to use casts? Or why do you think it's not important in your technique?
Yeah, I mean, not using cast is something new, and I think this is the only technique, rhinoplasty, without a cast. So I think this is very important. And the trick is, I don't do let down, I do push down. Because if you do let down, you're going to remove lots of bone. And then your bone is going to touch to the maxilla on the sides, but it's not going to go inside of it. Okay. But if you don't remove the bone is going to go inside, and it's going to be trapped on the antrum. So it cannot move to the sides. And then I use my suture, Theodore suture, going from the dorsum, and I'm going to fix it. If you check my Instagram page, then you're going to see this Theodore suture, how I do it. So you can, it's very easy. You can use it. I do it with a needle and just pass from here, and I'm going to tighten the knot inside over the mucosa. So it's going to be fixed. All this bony pyramid is going to go down, and with the suture, it cannot go up, and it cannot go to the sides because it's trapped on the nasal antrum.
Okay.
On the maxilla. So it's going to be fixed. So at the end of surgery, I always check this. I take my patients and I turn to the sides with this bony pyramid, and I feel that the bony pyramid is very well fixed. Then why should I use a cast?
Okay, and the Theodore suture, you put it, the knot goes inside mucosa or outside?
This is outside of the mucosa.
Outside.
At the end of the surgery, if you look inside the nose, you're going to see the suture. It's a 5-0 PDS suture, and it's going to resolve in like 2 weeks to 3 weeks.
So you don't remove it, right?
No, you're going to leave it there.
Okay, all right. Have you ever tried to use the tail strut with preservation of interdermal ligament?
Say it again. Have
Uh,
you ever tried this?
yeah, actually, I'm doing some cases, um, preserving the interdomal ligament and using it like a sling over the septal extension graft. Have you ever tried to use with the interdomal ligament?
Yeah, in the past, like 15 years ago, I tried many of them. I
Or,
tried everything. If you ask me, did you try it, I can tell you. 95% I will say yes, I tried. It works very well. Actually, this is a very good idea. This is one of the best, attempts in my career that, it worked very well. But the very important problem is the interdomal ligament is not at the dome. We call it
yeah,
interdomal, but it's not interdomal. It's subdomal ligament. And
yeah,
this ligament is going to carry your tip at this level, but the rest of your tip is going to collapse. You understand what I mean? The
yeah,
difference this is the difference of theostrat with all other extension grafts and everything. This is not only the fixation, but where you fixate it. It's a single point fixation, but to the top of the dome point. That's the trick. If you do it on the top of the tip point, and then there is nothing to collapse, if you put it there and you have a 2 millimeters, 4 millimeters tip cartilages still going there, they are going to be staying very well on the table. In your surgery, you're going to say, well, they are very strong. They are not never ever going to collapse. And they're going to collapse in 1 week. And your patient is going to tell you, my tip collapsed. And you're going to say, holy, I know it. That happened to me for 20 years. So I learned it.
yeah. And all right, just some more questions here. So exactly, you suture your tail strut suture pass. The first one, from what I understood, is on the back of the strut, and the second one passed through the strut. Is that correct?
Now, first of all, you have the tail strut. You have 2 domes, and you're gonna put the figure of 8 interdomal sutures behind the tail strut. Okay,
right.
And then at this point, with this figure of 8 sutures, the domes gonna be standing on the tail strut. In a closed rhinoplasty, in an open rhinoplasty, if you close the noise, you're gonna see the tail strut like this, and the both alar cartilages are going to be standing on the tail struts. So you can make it more projected or less projected with your hand. And then you're gonna make like Dr. Paul is asking, you're gonna make a round suture and you're gonna tie it. You're gonna say, yeah, it should be like this, the projection, not more, not less. You're gonna tie it and you're gonna check it again. And if it is good, and then you're gonna put another suture just for fixation, for security, for the long term. Single loop suture is not going to work. If your tip is going to be out of the tail strut, then it's going to be, you're going to lose everything here. Then it's going to go to the revision. So it should be very well stable.
Okay.
But not too stable. You should not suture everything to the tail strut. It's just on the top.
Okay. Yeah, and one more question here, Tel. When you do push down, in some cases, if you have widening of the cartilage dorsum, what maneuver do you use to narrow it?
Yeah, it's a very good question. And, there was a discussion of Dr. Gyron on one of these papers. I also put as a reference on my book. He says as a sentence, if there is something in excess, it has to go somewhere. If we make a reduction of bone and blah blah blah, but let's talk about the upper lateral cartilage. If we have an excess upper lateral cartilage and we push down, it's going to go somewhere. And if it cannot go up, it's going to go to the sides. It's going to be huge noise. So we have to make a reduction of the upper lateral cartilage. So how you do it is, I don't know, some I forgot the numbers of steps. It's one of the steps in my surgery, 15th step 15, I think. So you go and you're gonna cut the top of the both sides of the upper lateral cartilage, and then this excess tissue of the upper lateral cartilage, they're gonna go up like this, and you're gonna trim the excess.
Okay.
So you're gonna make a reduction of the upper lateral cartilage, and then you're gonna make a very simple fixation with a single suture on both sides. This is very important step of the operation. Otherwise, all your patients gonna come back to you and they're gonna say, you know, this is the problem of with all preservation techniques. You're gonna push everything down, and the upper lateral cartilage is gonna get huge on the size. You have to make a reduction of it.
Okay.
This is the way of like Dr. Saban does this reduction. He also does,
Okay.
you know, he's going to cut both sides and he can make a reduction of the upper lateral cartilage.
Are you performing this preservation dorsum in maybe 100% of your cases?
Yes, I do 100% exactly the same thing in all my cases. I never ever change. I never return to my old techniques like, you know, rasping and lateral osteotomies. I never done it again. You know, I always do the same. I start and end. But, you know, sometimes I change something because, you know, I want to try something new. That can happen. But, you know, I know what I'm trying to improve, and, you know, but I'm not changing my technique.
Okay, all right. Do you even on secondary cases, or it changes on secondary cases?
Well, secondary cases are, you know, you never know what you're gonna face when you open the case. So in a secondary case, everything is good in a good conditions. The anatomy is okay. Then I'm going to do exactly like a primary case. But, you know, if I cannot find the theostratus, then I'm gonna, you know, in a recent case, I sutured 3 cartilages together to make a theostrat. You know, this is normal, something that I never do. But the thing that helps me most in my technique in secondary cases is theostrat. Now, if you can put the theostrat in a secondary cases, then you are saved.
Okay. All right. Just a few more questions, okay? So I know it's late night in Turkey. Okay. Dear doctor, how you choose the fixation height of the domes? How much it has to be higher if compared with the dorsum? The relationship between dorsum and tip. How do you manage that?
You know, my friend Süreyya Şener'dir, you know, I know him for 20 years now, and, you know, I know all his operations. He always measured the dorsum and the tip. And he was says 4 millimeters, 8 millimeters, ladies, blah 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 blah. He has strict rules for this measurements. You know, I never ever measured this difference. I don't know. I cannot answer this question. But, you know, the thing is, this is in my book. You know, if you look from the side to the nose, this point on the supratip area and this point, the measurement between this point should be less than the preoperative shape of the patient. And then you're going to have a nice tip shape. And then you're going to have a supratip breakpoint. And you have to squeeze a little bit the tip, because, you know, with our hand at the beginning of the operation, what we do to shape a nice, beautiful tip shape, you're going to squeeze it a little bit. So in the operation, we also have to squeeze it a little bit.
Okay.
So this is what I do.
Okay, and can you use from Jefferson, colleague from my city here? Have you ever used 2 tail struts, one each side, in cases you need more strength?
You can't use 2 tail struts. I mean, tail strut is just one tail strut you can use. But, you know, it happened to me almost twice, not more than 2 times, I think. You know, I didn't have enough cartilage in a secondary case, and I sutured one cartilage to another one to make a longer and more stronger tail strut. But still, at the end, I have one single tail strut. You can't use them. You
Okay.
can't use two Teostat.
All right. And is there any difference between men and women?
Not really. You know, at the end, it's always my plan. And at the beginning of the operation, like step one, I show you. You know, I'm going to shape it my hand. I look her face. If I like this shape, I'm going to do it.
Okay. Okay. All right. Let's go for maybe last question, Tel. I know you're tired. Um, okay, here from Angel. How do you avoid a medial valve insufficiency with upper lateral crural trimming?
But medial valve insufficiency has, in my opinion, has nothing to do with upper lateral cartilage trimming. Because, you know, upper lateral cartilage is going to be stable anyway. But if you trim too much upper lateral cartilage, then it's going to be visible. You know, if you trim too much, you're going to have a, you know, too much reduction there, and it's going to be a deformity. You're going to see a depression on the upper lateral cartilage. Of course, you don't have to trim it too much. You know, you have to trim it so that, you know, the upper lateral cartilage, the upper part of the upper lateral cartilage is going to be on the same level with the dorsum.
Okay.
But not too much lower. If you make too much lower, then it's a big trouble. But normally, you should not have any problem with the medial valve insufficiency. And medial valve insufficiency is actually very well corrected with Teostat. You have to try it because, you know, the dome point is going to stay there, and then the skull ligament is going to be very stable. Everything is going to be very stable, not because they are very strong, but they're going to be standing stable. There are lots of talks in my book about this theoretical things like what happens, why happens with Teostat, and, you know, all these physiological changes and dynamics.
All right, Tel. Okay, Tel, we have already 1.5 hours. I would like to thank you so much, okay, for your lecture. For people here who were part of our mentoring, Tel is going to be this weekend exclusively in our WhatsApp group. He's going to be
I will be answering the questions.
Yeah, thank you so much, Tel, for the opportunity. And thank you so much again for everything and for teaching us these very nice maneuvers. I know that it can help anybody here, even if you do structured or preservation rhinoplasty. Thank you so much.
I thank you very much, Fernando. See you then.
All right, okay. So thank you, guys. Thank you. Gracias a todos amigos de Latinoamérica. Teşekkürler, people from Turkey. Thank you, everybody from all over the world. It was very nice live again. And next week, don't forget, we start our rhinoplasty mentoring week. We have some videos, nice videos with techniques about preservation rhinoplasty. And it's going to be a pleasure to be with everybody. Thank you again, Tel. Have a nice evening.
Thank you, guys, for joining.
Bye-bye. Thank you.
Bye.